So thank you for joining today's webinar, the Trilogy Laser webinar series. This is number 2. Today we are particularly focusing on the lower body, and in regards to the lower body, different pain sites, whether it be lower back pain, hip pain, knee, etc. We'll be covering everything. And we can have a chat at the end towards the end. We'll do a Q&A. And when we do that Q&A, I would expect, if you have a question, I want you to put it in the chat under the menu bar. So you'll see chat and you can put your question in there. You know, I won't be able to cover every single pain location of the lower body, but if you have a question about another area we didn't cover as well, feel free to ask what I might do there. Okay, so my name is Emrys Goldsworthy. You probably remember from last week. If you haven't seen last week's video, have a look before. If you find that last week's video was helpful and the way I've approached treating the upper body, which was last week, you found that helpful, then you should find today the same, if not more so, because we're only going to focus on the practicalities of laser rather than the theory. So I think that's good for a lot of clinicians. I'm going to talk about the use of laser from the perspective of someone who uses it on a daily basis, where things go right, where things can go wrong, had a workshop making a treatment work better when the protocols don't work. Okay, so one of the key things you'll see about my method is that I particularly aim for nerves, right? But there is a caveat to that, and that is that when I'm approaching sort of a reparative approach, which is basically a low dose, anything under 150 hertz of the laser at no more than 30 seconds, you should be getting a tissue repair effect. An LED cluster works as well for this. LED and laser work well for both, for analgesia as well, but the difference will be the depth. So laser will obviously go a bit deeper, LEDs less so. All right, so if you are dealing with pain, and a lot of the time you're dealing with both pain and tissue repair required, then you need to do a bit of both. So be careful where you apply it. So for example, you've got a ligament tear and you've got a localized nerve pain with that tear, which you always will. You'll treat that nerve pain separately to the tissue damage with a different approach. So you'll use the tissue repair protocol, which is under 150 hertz, like I've mentioned. And if you are wanting to deal with the pain, you'll aim for the site of pain, which will be the nerve most likely, and you'll use a 1 to 2 minutes over 150 hertz, and preferably the laser. Okay. I will also, as we're going along, if I see someone ask a question, and it's a really important question to answer as I'm going along, I will answer it before the end Q&A. Okay. So I'll answer them in real time. All right. So today is for an hour. I'll probably just have to go just over 1, but we'll see how we go. Now, contraindications, there's not many for laser, to be honest. We're going to be focusing on high intensity and low dose or low level laser or cold laser. They're all sort of under the banner of photobiomodulation. And as a general rule, over the area of malignancy is contraindicated, so any kind of cancer sites, and over the abdomen of a pregnant woman. The other area is, of course, the eyes, but the difference there is that LED clusters are fine over the eyes. So I won't call that a contraindication, more of a precaution. So anything over the eyes needs to be an LED light, not a laser. Okay. And I've listed the standards. You can have a read through of this. This is just for depending on your state. Talk to your insurer about where you stand as to what you need as far as certificates and what kind of insurance you need. Every state's different. Every state has a different sort of law about it all. So some don't even care. Some states don't have any laws about it, basically. But if you're in Queensland, then, you know, a 3B laser, for example, which is a cold laser, basically doesn't need much at all to apply. It's not really regulated. You do need safety certificates and things like that, which is part of this course. But other than that, the class 4 lasers is where you might run into an issue, but you just talk to your insurer and it's fine. And after you've done these courses, I think you'll be absolutely fine to go ahead. We're going to start with lower back pain. I mean, this is a very common symptom that you're going to get in the clinic: neck pain, back pain, shoulder pain, knee pain. So they're top 4. Back pain, you know, whether it's mechanical, constant, no mechanical component, ache, deep pain, superficial pain, pain associated with pins and needles, numbness, it doesn't really matter. I still want you to approach it the same way. Someone might describe their back pain as the back stiffness instead of pain. You know, these are all really the same problem. Pain is pain, and it can manifest in many different ways. So just be aware of that. Approaching it is important in a way that affects things that could be promoting guarding. So some people have stiffness in their back, and it's really just guarding something. Could be an injury. You know, they might have actually torn a ligament. They might have torn a muscle. It's not that easy to do in the lumbar, but it can happen. They might have had an annular tear in the disc. You know, these things happen. They do heal. Disc bulges aren't as scary as they used to be in the vernacular. You know, now disc bulges are, you know, even considered able to completely self-repair if they're doing the right things. So I don't want to focus on pathology. I want to focus on pain as a mechanism and neural entrapment as a cause. So we're going to start with what I would call the most common cause of central back pain, which is the dorsal rami entrapment. So to laser these points of pain, you're going to have to get the laser right beside, and you're going to use palpation. You know, you've got to feel for, you know, with your thumb, or whether you use an IASTM tool or something, push in to find that facet laminar region of the spine. And you're going to basically find a tender point in there. And that point is the dorsal rami, because it's that deeper portion of the dorsal rami that we're going to treat. And I've indicated it here with the red and black X's. These nerves are coming out of the lumbar foramina, intervertebral foramina, and their entrapment can occur outside of that facet joint and along the lamina, okay? And it can cause a lot of guarding, guarding of multifidi, so they reflexively contract, and some of the erector groups as well, particularly multifidi and rotatories there, and sometimes quadratus lumborum and intertransversarii, which are the muscles in between the transverse processes. Now, additional to that is the superior gluteal cutaneous nerve, and that is also known as the cluneal nerve or superior cluneal nerve. And you'll see here along that iliac crest, this is the posterior view of the lumbar, and that bone where those green crosses are is the iliac crest, the posterior aspect, just superior to the PSIS. So going back, the dorsal rami, superior gluteal cutaneous nerve. These nerves are particularly important for dealing with frank lumbar pain, situated either centrally or just lateral. The cluneal or the gluteal cutaneous, not to be confused with the just the normal gluteal nerves, these present as more lateral pain, whereas the dorsal rami can be lateral, but it's predominantly that medial facet joint, you know, kind of area pain that people experience. And it can present with any motion, flexion, extension, rotation, lateral flexion, because wherever that nerve is entrapped, often any articulation, particularly some kind of quadrant motion, whether it be rotation and lateral flexion extension into the lumbar of that same side, will often bring on that pain. And we get taught as clinicians that that's facet joint often and nerve root, but I would like to challenge that and say dorsal rami. It's far more likely to be dorsal rami as it's already exited at the lamina, okay? And maybe this is a bit new for some people, this concept, but I'm not really going to mention muscles other than the fact that muscles guard. And there is a thing where muscles guarding can cause nerve pain as well, because muscles can be embedded, nerves can be embedded through muscles, not unlike how the piriformis can have the sciatic nerve through it. Your femoral nerve can go through the psoas. Lots of nerves go through muscles. And if those nerves get irritated, those muscles can guard, and then whatever nerve runs through those muscles or close by can often get entrapped by the contractile muscle itself. So it's really about what starts it off. If you can figure that out, then you're going to deal with the guarding mechanism, which will inherently deal with the nerve entrapment from the guarding. And no matter what it is, you know, it's very difficult to analyze what the source of pain is based on what direction is painful in lumbar motion. But one thing's for certain is that nerves are the cause of pain. Without nerves, you don't have pain. Nerves, including the brain, are all connected as one system, the nervous system. And without nerves, you can't transmit pain to the brain. You can't transmit nociception, which then becomes pain as an experience. Okay, moving on. So the other area of pain is down at the sacrum. You often get this around the sacroiliac joint or along the sort of medial aspect of the sacrum, those sacral foramina regions. And that's really common pain. The pain presents as sort of, they'll rub the sacrum on one side slightly. Maybe they'll say, oh, it hurts in the joint, you know, around that PSIS area. Maybe they'll say it extends into the glute. Well, one thing's for certain is that if you are dealing with pain in this area, you're going to have to consider that it's coming from the medial gluteal cutaneous nerve. It's another cutaneous gluteal nerve, aka cluneal, medial cluneal nerve, and it comes out as a superficial nerve, and it hurts to touch the area. You push down and those nerves are there. That's what you're pushing on. You ever wondered why it hurts to push on the foramina? You probably think maybe multifidi. I think you should reconsider. You should reconsider it to be the medial gluteal cutaneous nerves. And they go into the sacroiliac joint area, the posterior aspect, and they can mimic SIJ pain, okay? The superior gluteal nerve itself actually runs anterior to the SIJ, sacroiliac joint, and is famously, and at least in my circles, the cause of the pain associated with sacroiliac joint instability. So when you have a sacroiliac joint that is really unstable, it's moving in a way that's aberrant. In other words, it's not locking upon weight bearing or sitting. Sometimes it's not locking, the joint's not locking together that it should. This nerve often gets irritated, and it results in its innervated muscles, i.e. gluteus medius and minimus and TFL. These muscles all guard, maybe one, maybe two, but all three often guard, and they become tight. And it's because the entrapment of that nerve is occurring, tending to be deep to the sacroiliac joint line, but accessible with laser, at the very least accessible at a point here indicated by the red and black. And this area is just lateral and inferior to the PSIS. This area, everyone will know about this tender spot and those tender spots around, okay? And this is a deep nerve, so you have to push. Are there any questions about what I'm talking about? Now, I'm applying a laser approach of analgesia here, which means you need to do at least a minute per point. And if you're using the high intensity laser, this is the one that requires tracking, which means you need to be moving the laser. You need to be moving it along the nerve pathways, up and down, sort of bringing in each of these points as you go along. So I might scan from that most superior X all the way down and back up again, and continuously doing that so that you get at least a couple of minutes per region with the laser. Excuse me. Like I said, don't forget any questions, go to the chat up the top and put in your question. All right, so we've done sacroiliac joint pain, and a little caveat to the sacroiliac joint pain with the superior gluteal nerve is that often it's great in theory to treat nerve entrapment, but if you don't deal with the strength deficits of someone's lumbopelvic area, often it won't resolve. You know, a sacroiliac belt often is a great indicator that it's instability. They put the belt on, it stabilizes that joint, and their pain reduces, including the nerve pain. So you need to consider, how do I do that? The laser itself won't do that. So you need to start looking at a rehab program. Often, excuse me, often that includes pelvic floor, abdominal wall strengthening, sometimes diaphragm can be incorporated, multifidi strengthening, gluteal, adductor. Generally speaking, though, I think that lower body strength is really important. The lower body, the glutes, the hamstrings, the quads, the adductors, these all play a really big role in deloading that sacroiliac joint, but more indirectly, because there's less sort of upwards force into the sacroiliac joint because the quads and the knees take more load and they are able to, you know, they're not buckling because of some weakness issue you have in the quads and hamstrings, as an example. Same goes for knee pain. No matter what, if you've got a patient that's not responding long-term to laser, they get an immediate improvement, but it comes back, I mean, nearly always it's a instability problem. They're weak and they need to get strong. Nearly always. Or you need something stronger than laser, like shockwave therapy. And that's why I think the two together are perfect. Shockwave therapy in conjunction with laser therapy is just win-win. The likelihood of it not working is dramatically lowered. So laser itself is very successful therapy on most cases, vast majority of cases. But when you know, some people just use shockwave and they get the same thing. You know, you need to often combine therapies to get a better result. And with shockwave, I apply it often in a very similar way to the laser. So lateral hip. So this is the kind of case where someone comes in and says, my TFL is sore, or I've got this pain in the lateral area of my hip, just below my iliac crest laterally, just above graduate canter. You know, often they'll have diagnoses like trochanteric pain syndrome or gluteal tendinopathy, something like that. Okay. Often they'll have an osteoarthritis diagnosis too. Excuse me. And this is where we really need to just sort of look away from these diagnoses for a second and consider that the pain may be coming from somewhere else, even with those diagnoses. So let's start with the iliohypogastric nerve and its extension that goes lateral hip area above the gluteus medius. You can see here the X's. It's coming off the lateral trunk region, coming over the bone there, and as it goes over that iliac crest, that superior area of the image, that first X, that area is a prime zone of entrapment. As it crosses over bone, and then it enters into that region, and often is a really common nerve, comes up great after shockwave and laser. A lot of pain is reduced, and a lot of people don't even look in these areas. You sort of have to palpate along that bone, that iliac crest laterally, and you'll find there's a little bit of a thread of pain underneath. And that's the nerve, the iliohypogastric nerve. And this other X that I've put here, hang on a second. No, let me come off that again. Go back, sorry. This other X you'll see here that looks like it's just in the middle of the muscle, the one that's lateral inferior of the image, which is technically anterior. That's a deeper portion of this nerve that goes through. And you can see at the bottom of that X, there's a little peeking out nerve, and that's still the iliohypogastric nerve. So you've got to find where it hurts basically in this nerve and point the laser. Using a low-level laser approach, 1 minute per point, maybe 2 max, have an analgesic effect. And if you're using the high intensity, where you're going to be scanning up and down the region, covering all these points. Okay. All right. Superior gluteal nerve. Now, this is really just the same area, but deeper. And that muscle you can see is the gluteus minimus. Now, you've already looked at this before, but you looked at it from a posterior view. This is a lateral view, and it actually extends all the way to underneath that TFL, which has been removed from this image. This is a lateral view. Don't forget, lateral view of the pelvis. You can see the lumbar spine. So often you'll have to palpate quite deep to find these points. But if you go back, those points are distinctly different to the iliohypogastric nerve. Okay. Any questions? Don't forget, feel free to put them in the chat. Now, what I do find with the lateral hip problems is that often these nerve issues that I'm talking about, so often they're not just isolated to the area of pain. You often get a secondary problem in it, or it's the primary issue. It's just not the presenting issue. For example, a case in point that I'm referring to is a case where a person presented with the superior gluteal nerve entrapment, and they also had other symptoms. Okay, one was a fibular nerve entrapment further down the leg, which resulted in lateral calf pain or lateral leg pain. And they also had this shoulder blade pain, which was dorsal scapular nerve, which was covered last week. Now, what I've found is that when I treated the superior gluteal nerve, which resolved the pain, at least in the session, in the great, much more big improvements in range of motion, less tenderness upon palpation, that kind of thing. They found that those other areas would change too, like they would get less intense. And what I found is that when I didn't treat them, particularly in the first visit, there was other issues as well. That this hip pain, this lateral hip pain, didn't improve so much after. It actually came back. Following visit, I brought in treatment to the dorsal scapular nerve before I treated the superior gluteal nerve. And the superior gluteal nerve was much easier to treat and required much less time to get it good. And that treatment lasted far longer. In fact, it didn't even really properly return to where it was. It just had a small neural tension sensation in the area thereafter. So the pain was different, the symptoms were different, and we got on top of it pretty much after that. It's really important to always incorporate the other areas of concern because they may be playing in on the main symptom, because the nervous system is one structure. It's really important not to just subdivide it like we do, like I'm doing now, but in essence, it's best to always work the whole nervous system as far as where the person feels problems. Don't let any stone be left unturned. Okay. Let's get to hip pain. So anterior hip pain, front of the hip, and also groin pain. I'll just put them as one. So this is a very complicated picture, and I understand that it's a bit hard to follow. The anterior hip is a very complex region. I've not got every structure in this. Obviously, it's missing blood vessels and some of the abdominal musculature. So what you can see here is this big long tendon. There's actually two muscles here. That's the iliopsoas that's coming downwards. And then you've got your adductors or the medial side. And then laterally, you've got gluteals and rectus femoris, the big white tendon. Now, the femoral nerve is of great concern for anterior hip pain that is situated around the hip socket anteriorly. And, you know, you'll find that often it hurts to touch just underneath that inguinal ligament, that long ligament across the front there. The genitofemoral nerve is listed as the green or yellow X. They're also intertwined, it's hard to see. But the main thing is that when you palpate the area, it's highly unlikely you're going to be able to differentiate the nerves here, okay? So you're going to have to find that that inguinal ligament, and above and below that, palpate superior lateral for those iliohypogastric ilioinguinal nerves, inferior and superior medial for genitofemoral, and just centrally where you are, straight over the middle, should be all the femoral nerves. Now, femoral nerve branches off into the deep femoral nerves, which we'll go through in a second, and it also goes into the saphenous nerve. Saphenous nerve is very important. And so I often have to treat knee nervous system tension, which you will do next, to help hip. Or if the knee doesn't resolve from whatever I show you soon, then you should do the hip. They're basically all the same nerves. They're just coming, you just treat them in different parts of it. So really important to remember that. The white X is the lateral femoral cutaneous nerve, and it's not as common as you might think. It does often present as lateral thigh pain, lateral hip, anterior lateral hip, and I don't think it's that common. I probably get one every month that's that. The rest are femoral nerve and obturator nerve. You have a look at that obturator nerve there. It's not visible underneath that adductor though, it's under there. That one's the more medial of them all, the obturator nerve, and you've got to get right in there, just lateral to the pubic bone, the pubic tubercle. In that area, pectineus, often called pectineus pain, obturator nerve entrapment there. Going back to the lateral femoral cutaneous nerve, it often presents as numbness paresthesia in the lateral thigh. That's a neuralgia paresthetica. That's the condition that's called. But that one is particularly associated with entrapment that is medial posterior to the ASIS. So that's that higher white X. Very important area to look at. Often though, you need to physically mobilize that nerve with some kind of tool. I often use things like these. These, like, you can't see me, but you might be able to see me actually. Just double check you can see me. Yep, this tool here, this is just a simple tool, and there's actually some cool new tools that, just like IASTM tools like this, that Asta's brought out. So have a look at those. And you can use them to manipulate nerves when they're getting stuck and you want to mobilize them with stuff like that. Shockwave too. So anterior hip pain, often associated with osteoarthritic hips, labral tears, tendinopathies of the rectus femoris, iliopsoas, that kind of thing. Look, to be honest, I definitely find that they're misdiagnosed as the cause of pain. That's not to say they don't exist. It's just that I don't really buy into them being the cause of pain most of the time. And sometimes you have really bad tears in the labrum of the hip. And I see it a lot because I treat a lot of ballet dancers and gymnasts. There's a lot of tears there for them. And their hips are incredibly mobile and they're very clicky. clicky, you know, so because of that hypermobility. And they're often really just unstable. They've got nerve entrapments, often from just excessive movement of that joint. Yeah, they got tears, but you know, a lot of people have labral tears and wouldn't know about it. I can tell you now, it's not exclusively painful. It's often associated with like a grind or a catching noise, like a click or a snap that's inside the joint. As far as we're aware, that's associated. I don't buy that it's inherently painful. You need to have the nerve entrapment with it to be painful, I believe. That's my belief now after years of treating this. So there's a question, does laser help to heal the labral tears? Now, I mean, it's controversial because we haven't done a study on every individual tissue type, but you can cross-reference other studies done on ligaments and tendons, and it does help to repair. So when you use laser at a low dose, it's a low dose approach. Like I said before, if you're dealing with a tear, you do want to treat it. You want to presume that it will help. Don't just leave it, you know. So tendinopathies as well, ligament tears and labral tears, as well as many other types of tears and also fractures. Applying the laser at a low dose, 30 seconds, or the LED in this case, you could use that, but it would be better to use the laser because of the depth of that labrum. So you remember how to palpate that labrum over the anterior hip, basically where the socket is. You just go through your anatomy text and you'll be fine to help you palpate that. It protrudes slightly, so that acetabulum protrudes slightly and you can feel it. That area, using the laser will be about 30 seconds at under 150 hertz. And then you can look at all the other pain points, as I've mentioned here. Okay. So that doesn't take very long. Often these treatments are quite quick once you know what you're dealing with. But I would recommend adding on some soft tissue manipulation if you know what you're doing, or shockwave if you've got it, and rehab where appropriate. Okay. You might have other therapies you use, which go right ahead. Laser shouldn't really be getting in the way of them, and they shouldn't get in the way of laser. I also do dry needling often with electric current, more so. And they work well with laser too. So, you know, one doesn't precede the other. I still find laser to be a really important part. In fact, sometimes it's the only option. That's the good thing about laser, is that when everything else is not an option, often laser is, because of the nature of it being low. It's not invasive. All right, let's get onto the knee, and everything in the knee applies to the thigh as well, but I'm going to focus on the knee. Okay, so the femoral nerve subdivides into the saphenous and genicular nerves. So we're going to predominantly be focusing on the genicular nerves, which are the nerves just above the patella and also around the knee. Excuse me. The common fibular nerve, which wraps around for parts of the knee, and the saphenous nerve, which runs medial. Okay, so you can see here on the left the saphenous nerve. Now I've got two X's there because you can't see the saphenous nerve, but it runs deep to the gracilis, and this area is really important to laser. It's a really important entrapment site. The other area is a bit lower, and you can see on the chart it says infrapatellar branch of the saphenous nerve, and you'll be able to palpate that with either a tool, like I've said. Nails actually work really well because they're sharper, but most of the time you'll be able to, it'll just hurt to touch along that medial aspect. This is the medial knee, by the way. And it runs inferior anterior on the superior tibia. Okay. And you've also got another branch going down. One of the branches of the saphenous nerve goes into the medial gastroc, We'll get to that soon. And the rest of that saphenous nerve goes all the way down the shin, tibia, to the ankle. Okay, so these are very important areas. So I would be lasering all the way through that infrapatellar branch, anywhere along the whole saphenous nerve that's tender, anywhere it's sore to touch, and those X's that I've indicated on the left. Now, the genicular nerves. Now, this is one, I can't stress that enough. Now, the genicular nerves are a branch of the femoral. They are incredibly important. They are likely to be your favorite treatment for the knee now onwards. You will see the genicular branches here, as well as, now some of the genicular nerves come from other nerves as well. It just depends on, also it does depend on the text, but generally speaking, you'll be able to palpate them easily. You go to superior, medial, and lateral, and you'll be able to palpate these nerves deep. Some of them come through to the skin, and they hurt as like localized tender points, just medial, superior, and lateral above the patella, and just lateral and medial to the patella. And you'll see some other branches as well, some medial inferior genicular nerve as well. These nerves are where you need to put the laser, okay? You often need to massage them as well to get them moving. And they basically replicate nearly, unless it's very medial knee pain or saphenous nerve, very much so, saphenous nerve pain, they replicate at least 80% of, 70 to 80% of knee pain. That is what I believe is the cause of most knee pain, is these genicular nerves. So, I mean, obviously there's a lot of them, so it's not one individual, okay? But get acquainted with that image on the right, because that image alone, the endpoints of all of those nerves, you've also got the fibular nerve listed at the bottom there. Don't forget that one. That's more for lateral inferior knee pain. But all these nerves are prime targets for laser, okay? 1 minute each, okay? And scanning is an option as well. And you just move around the patella above and below, and basically getting as much of those nerves as you can as you are tracking. Okay. So calf pain, got a quarter of an hour left. Calf pain. So calf pain is, most people come with calf pain after calf tears, to be honest, but that can still be nerve pain. But some people come in with nerve pain distinctly as calf pain. It's not for any other reason other than entrapment. It's not as common, but it does happen. You know, you've got dealing with a left knee here. This shows the saphenous nerve coming around on the medial side, or the right-hand side, the medial side of the knee coming down to the back. This image shows the gastrocnemius and its attachments higher up onto the femur. The deeper tibial nerve entrapment site's really often high. Around where the soleus attaches to the tibia tends to be where the tibial nerve becomes a problem. The saphenous nerve, I've mentioned that, and the sural nerve branches, they're all types of cutaneous portions of the sural nerve running lateral. But I'll be honest, I think that you'll find that this image is as a guide only, because the nerve pain could be anywhere along those nerves. It doesn't have to be that X. Some though I will say that the tibial nerve points here are really common when there was enough pressure applied into the back of that calf and the side-to-side motion. Often nerves need to be sort of palpated transversely across the fibers rather than along the fibers to replicate the pain associated with them. I don't use a lot of neurodynamic testing to know if it's nerve, because with the research done on neurodynamic testing, it shows that they don't really always bring it on when it's there. Saw one study for carpal tunnel syndrome, and the median nerve tension test was positive 50% of the time in carpal tunnel syndrome positive patients. So it's got a pretty low hit rate. I think they're useful, but I think that palpation is more useful. At least that's my opinion now. It might change. But right now, I don't use them exclusively to figure out where their pain source is or what nerve it is. And I mean, it's useful in certain, they've got shoulder pain when they lift their arm with external rotation rather than internal rotation. And then what nerves are more in tension with external rotation, and what, if it was worse with internal, what nerves are more on tension with internal. That way, I think it's useful. But other than that, I don't think I use it anywhere near as much as I used to, particularly after I came out of uni. I used it a lot, but you often use testing less and less compared to when you first started, because you realize how useless some of the tests are. Okay, shin pain. So this is for anyone who presents with anterolateral shin pain or that medial tibial shin pain. So this is that lateral shin pain, tib-ant, perineal kind of pain. You've got here the deep fibular nerve running under the tibialis anterior, really common pain. Often causes foot pain too, entrapment higher up. Particularly between the toes, big toe and the second toe, that's the deep fibular nerve pain that you often get from entrapment higher up all the way down. Superficial fibular nerve, that's the one that's more lateral. It goes more along the fibular nerve fibular bone. And you can see that the entrapment sites are all the way along. It's often many, many sites. And then you've got the less common lateral sural nerve that can come around, but it's a lot more superficial and it hurts with a lot less pressure. That I've probably only seen that once. I don't see that very common. The deep fibular nerve and the superficial fibular nerve, they're just at least a few times a week I'll see them. Okay. The medial shin pain, this is an anterior view of the shin, of the tibia, and you'll see that along that medial aspect, there's a whole bunch of areas that you can get entrapments. I often have to laser every individual tender point along that shin, along that tibia, or saphenous nerve. And it replicates that so-called medial tibial stress syndrome. I really am skeptical about that condition now. Yeah, you can get periostitis and things like that, but you wonder why it's often not easy to treat when you are treating it as if it's just an inflammatory attachment syndrome. I think that if you deal with it as a saphenous nerve problem, you're going to get a lot better results. It's not to say that weakness and issues with stability in the lower body is not a problem, or the fact that you can get fractures and stress fractures and things like that, stress reactions as well. But even that's controversial because stress reactions don't always cause pain. Pathologies, fractures, yeah, okay, I'll go with that. I think the stress fracture of the tibia is definitely a huge player in reduction of pain. But I wouldn't be surprised that the fracture itself gets less and less painful over the weeks. It's a stress fracture, Stress fractures are often referred to as adaptive fracturing rather than frank, traumatic fracture, because they happen over time and they happen as a result of consistent overuse or misuse because of a poor flooring that an athlete might be on, or grounds might be wrong, the hard flooring for certain disciplines of different sports, different shoes. Sometimes, you can't always associate them. It's a real bias towards pronation as a cause, which I don't always buy. From my perspective, I treat a lot of ballet dancers, and the single most important thing as a ballet dancer is that they land in, because all ballet dancers train in turnout. In other words, external hip rotation. Their feet sit in a 90-degree angle, 180 degrees outwards, and they have to land that way. So their feet must point out, their knees must go over their toes. What often happens is their knees go forward and their toes go out. And that puts an undue stress through the tibia. Most ballet dancers need more hip turnout, and that's how you resolve their problems. Because ballet dancers can't not have turnout. It's like most often the cure of most ballet technique problems is a lack of turnout. So as much as it doesn't seem right to the average person, making someone have more and more hip rotation is better than them not having it, because there's far more problems associated with not having it because of the nature of the mechanics of dance and ballet. Okay, it's the same if you go to other things. It's just that you need to consider the whole kinetic chain, the hip position when they land, the knee position, which is mostly to do with the hip, that sort of thing. But I would be lasering this whole line. Each point, 1 to 2 minutes. Very important when you're treating medial tibial pain. All right, Achilles pain. Now, of course, with an Achilles tendinopathy or a tear, you're going to be using the 30 seconds or so reparative approach over the tendinopathy area, which tends to be the mid portion. Could be insertional Achilles pain and tendinopathy. So you would approach that with a 30 seconds there as well. But consider that it's actually nerve pain as well. And mostly it's sural nerve. So the sural nerve runs lateral, and often, in many cases, it's not that anterior as in this image is. This is a lateral view of the ankle. And the actual nerve often runs and sticks to the Achilles. And that's where it goes wrong. But you can laser and treat it all the way down into the lateral calcaneal area and foot. Very important, that one. Heel pain. Well, this is a common one, isn't it? Plantar fasciitis, the most common diagnosis you're going to hear for heel pain. Maybe a fat pad, but it's mostly plantar fasciopathy. 2 nerves of concern, really. Medial calcaneal nerve, that's the most likely to be causing the plantar fasciitis pain, and a little bit of plantar nerves as listed here. You can see the purple, pink. But that medial calcaneal nerve, you'll feel it on that medial attachment site of the plantar fascia. There's an actual area where the nerve runs in there, and that area is a key important area to laser, I can tell you now. Sometimes you can get plantar fascia tears that are more in the middle of the plantar fascia, not at the attachment. It doesn't have to be at attachment medially, like most commonly you'll palpate there, but it can be anywhere along the plantar fascia. I've had patients where it's more anterior, not on the insertion or the attachment points. So it's very commonly the case that you'll have to use a reparative laser approach somewhere along the mid portion of that plantar fascia, because it is the connective tissue structure, and then applying analgesic approaches to the nerves as shown here. All right, it's time for questions. Any questions, everyone? I'll open up the chat and we can start. Well, hopefully that wasn't too monotonous of basically the same kind of ideas over and over again, but I guess that's how it works when you're doing laser. You're applying the same approach to different regions. Okay. Any questions? It's not as many on today, so I'm sure that the likelihood is less. Okay. Buttock. Oh. Well, look, there's a question about with glute and how deep is the laser going. I think you could argue that you could at least get to the gluteus minimus, and therefore we're able to get to superior gluteal nerve, as I've shown. It's important to press the laser in so that you don't have to, like I often will push the laser down, or I'll hold the tissue and I'll push the glute muscle in to create less distance. Push that tissue down, place the laser on top, then laser there. That will give you more like opportunity to get it deeper. Same for anywhere. If you wanted to go deeper, push the tissue into the body so that it gets compressed, and then the laser should be able to penetrate more of it. At least theoretically, that should work. And I've noticed that works. So it's just, it makes sense. Any other questions about some of those things? I'm sure a lot of it's a bit overwhelming, dealing with nerves. If you haven't done much nerve work, yeah. How deep is low-level laser going? Question. Well, look, different light colors have different depths. So I would say you could, because different studies show different things, right? So infrared is the deeper, near infrared is not as deep, and red is very superficial. So infrared, we should, at the very least, be able to penetrate the entire wrist. Should be able to go through that far, at least, okay? Are you going to be able to get that deep on the arm? Some light might get through, some energy, but if you think of it as that kind of depth, maybe there, that should be doable. It's just going to, the problem is that if you're trying to get something that deep, lower, like I'm just using this as an example, as a depth. If you're trying to get something that deep, the amount of light that is absorbed here versus here, more light is absorbed at the superficial, and the deeper you go, the less light is absorbed. So one important caveat here about treating deeper, hang on a second about the, I'll answer that question in a sec. The deeper that laser goes, the less energy that is there, right? So because it gets absorbed as it goes through, right? So if you want to apply, say, something like a minute, something superficial, well, you probably need to go closer to 2 minutes for something deeper. It's often the reason why I have to apply it twice. There's just not enough dose. And you've got to give things at least 10 minutes to take effect. 10 minutes minimum. Some things take a whole day. It's really hard then. You won't know with certain patients who haven't treated before, brand new patient. But most patients, it's either immediate or by 10 minutes. It should have had the analgesic effect. Question, deeper, the softer the tissue. No. It's more to do with water content, as far as I'm aware. And density, I would put it forward that the density of the tissue means it won't go as deep because there's more cells to absorb. And the more water there is in the area, there's water everywhere in the body, right? The more likelihood it will be absorbed. So it's going to get absorbed based on the amount of water content and density of cells. So if light gets absorbed by the mitochondria, which we talked about last week, the more mitochondria there is in that distance between there and there, the more likelihood of it being basically absorbed before it reaches that endpoint. I hope that answers that. Any other questions, guys? Well, thank you. Yeah. I hope you enjoyed today, and it will be as a recording. I'll be able to access this in the next few days. Had a good time. It was great to talk about laser again. Working clinically with laser, I can tell you now, I use laser, dry needling, electric current often, shockwave, cupping, instrument assisted, soft tissue manipulation, joint work, all sorts of, lots of techniques. I'm multimodal, use rehab as well, of course. I think that that's the way to go. If you can learn as many things as you can, but I will say that the introduction of laser made a huge difference to what I was able to treat and a huge difference to the results that I got, an incredible uptick, because it's something completely different to every other therapy. Manipulating a tissue is very mechanical. It causes a bit of irritation often. Laser is a way of dealing with that irritation, not to mention dealing with pain by itself. Also a great tissue repair enhancer. So when you're putting a treatment plan together, figure out what tissue needs repairing, if it does, whether it be a tendinopathy or a tear itself. And then look at what nerves are there based on what we did today in that area, okay? And if when in doubt, treat all of them. Just treat all those points, okay? You're not going to lose by treating one that's not the cause, right? You're only going to gain by covering all your bases, okay? And with 1 minute to 2 minutes per point, we'll make that point clear. The deeper the tissue, or deeper the nerve, go for closer to 2 minutes. And a higher hertz, 150 plus hertz. I often go to 5,000 hertz, 5 kilohertz, and that's very, very helpful. The higher hertz does help with analgesic effects. And use the lower hertz with the 30 seconds, and you're going to find that useful for reparative. When you're using the high intensity part of the laser, when you turn that up, the higher wattage, you're going to have to scan the area rather than hold it down at one point, because holding it more than likely will, because it's a hotter laser, it will make them feel pain and you want to pull it away. So just scanning the area with the laser at a somewhat distance. Sometimes you can go a bit higher, sometimes you can go a bit closer. Ask the patient, does it feel warm? Does it feel hot? Is it uncomfortable? And raise it and get closer based on just having a little bit of warmth. That's okay, but not too hot. All right? Otherwise, a low-level laser, you won't feel that at all. And so everything's just a hold on one point. Okay. Thanks, everyone. Have a lovely day. I'll see you again next week on Wednesday for the next webinar. Take care.